I will try to tell you something more about, in the next few minutes, about the possibilities for 3D live imaging guidance in the hybrid OR and the advantages that can afford you. These are my disclosures. Everybody will agree that vascular surgery has known a tremendous evolution during the last 2 or 3 decades, with the endovascular therapy taking over in many fields the open vascular procedures. And even in the endovascular field, a great step are taken and big evolution has taken place, so that instead of the very simple procedures that were performed in the beginning, now more and more complex procedures are being undertaken. These more complex procedures actually increase the need for 3D insight in anatomic relation of vessels, side branches, and lesions. And this is certainly the case, for instance, in fenestrated endografts for juxtarenal or thoracoabdominal aneurysms, but also in many other cases. Contrast and radiation are 2 important caveats in endovascular therapy, and we really have to find ways to avoid repeated contrast injections that are not necessary for the intervention itself. And we also need to reduce operative time and operation dose. Fusion techniques can be of an advantage there, and these fusion techniques with image guidance, they optimally use the available information from the preoperative CT or MR images to construct 3D images of the vascular tree, which will then be used as kind of a roadmap for the actual intervention. They also allow to define optimal angles and projections for visualization and catheterization, so that this has not to be done during the intervention itself, but can be done on beforehand. It allows that for less contrast injections when changing the C-arm position or projection. In fact, this is no longer necessary when we use these live image guidance software. And therefore, for all these reasons, it is able to significantly reduce contrast and radiation dose. The system that Philips developed in order to obtain these goals is a vessel navigator. And the vessel navigator actually is kind of a software tool which enables you to do these segmentation, planning, registration, and live guidance in a very, very easy and intuitive way. And that's the main advantage of the system, besides the fact that it's precise, of course, also. What does it consist of? Well, first of all, you have to create your vascular tree that you're going to use as a map, and this is done by segmentation techniques. Then you do the planning. You can add ring markers at the ostiums of the different side branches. You can plot the optimal angle and actually transfer that angle directly to your machine, so that with one simple push on the knob, your C-arm automatically goes to the desired position, which is the position of which you know that it gives you an optimal view of the side branches. Then you go to the registration, and registration previously had to be done always with a 3D cone beam CT or whatever registration before. Now it can also be done just with 2 simple radioscopy images, a 2D registration of the anatomy of the patient, which then is fused with the anatomy of the patient as we reconstructed it from the preoperatively obtained CT scans. And the last step, of course, is the live image guidance itself, with where we can select the preferred visualization as set with the preset angles, and the C-arm and the table movements can be followed and will be followed by the map that we made itself. Just to illustrate how easy this system is, this is the way that the segmentation is done. As you see, this is not automatically, but it allows you to choose those vessels which you want to be on the angiogram that is used for further road mapping. You just click on them, and they are put into the model, which you can turn around, see whether everything that you want to be in there is indeed segmented. The renal artery is still missing. You see the images also on the lateral side, and that's then the vascular tree as it is obtained. Next step is the planning step, and planning step consists of 2 parts. First, we make landmarks. Landmarks are placed at the ostium of the side branches. I don't know whether it close. Yes. A place at the ostium of side branches is done semi-automatically, but you can always adjust so that the ring marker is really at the ostium itself in the right direction, in the right angle. And this is very helpful for further catheterization. And the next step then is to define the right projection angle. As you know, for instance, in Evar, it's very important to use the right projection angle for your proximal neck. This can easily be determined by this system and then stored in the system itself so that with one push on up, you can immediately bring your C-arm to that position that was selected. And of course, the same can be done for the iliac levels to have the ideal visualization of the internal iliac artery. After planning, there is the registration, which is actually the fusing. So as you can see here, an AP and a lateral-lateral image were obtained. This is a 2D fusion, and both images are put together on each other. The autofate is a very useful tool, so you can see whether these really match to each other, both in the AP and in the lateral-lateral plane. When you do very complex aortic procedures, sometimes 3D registration might still be an advantage. And in that case, you use the calcifications, for instance, on the preoperative images, and you look at them on the cone beam CT, which is taken. And as you can see, these match very well. And these are taken, and when you take 3 of these points, then the patient and the anatomy of the patient is defined, and you can work further. And then the last step is the guidance itself, but we'll show some examples of that later. All this is done in our hybrid suite, and much of what we do can actually be done on the tables, at the table site itself. It's only the registration and planning that has to be done beforehand on the computer. The rest is done on the table site itself. You can use this for puncture of the femoral artery. I agree this is not a mixed indication, but it shows you the accurateness of the technique. And sometimes when you have iliac occlusions, where you do not feel pulses, this might be an advantage. Of course, you can also use ultrasound. It can be used for simple procedures. These are 2 procedures where we used it. One is an iliac stenosis, the other one was an iliac aneurysm, and both were performed with use of the vessel navigator. As you can see, it was in both cases very precise. You can see the overlay with the angiogram. We do use it routinely for carotid procedures because of the easiness with which the arch can be catheterized. Indeed, you no longer need to take an arch angiogram. And the ring marker shows you very precisely where to catheterize, in this case, the left common iliac artery. Obviously, the patient is never on the table in the same position as he was on the preoperative CT scan, so this is what you get when you go higher up. The patient, his head is clearly in another position, but then there is a possibility to adjust this image to each other so that in the rest of the operation you can work further again with this vessel navigator. One of the major indications, of course, is Evar procedures. This is a case where the actual delivery of the graft was made on the vessel navigator system itself, and control was only performed after partial deployment of the graft, which clearly diminishes the amount of contrast. When you like more the image with only an outline of the artery, that's possible also. This is not a device, and as you can see, the control angiogram shows that the position of the renal artery on the vessel navigator was exactly where it had to be, where it was on the angiogram, so that the position of the graft was correct also. One of the other problems that might occur is, of course, the fact that when you insert rigid devices, the iliac anatomy, certainly when it's tortuous, is changed. This is true, for sure. But in our experience, what we saw is that actually the iliac bifurcation is kind of a very stable place. I was a bit amazed by that, but the iliac bifurcation itself, so the point that's important for us, does not change a lot, probably because it is rather fixed in the pelvis. Other indications, iliac embolization. In this case, with an iliac aneurysm, we wanted to put a coil or an Amplatzer plug in the internal iliac artery, and the catheterization of the iliac artery was made very easy thanks to that system. Chimney grafts. You see that both renal arteries are catheterized through the ring markers, and the position is confirmed by a short angiogram. TEVAR procedures. On the right side, the vessel navigator. On the left side, you see the angiographic image. You see that both are very similar. And actually, you have even a bit more information on the vessel navigator than on the actual angiographic control. All these things are performed in the hybrid room in our hospital, which is a FlexMove Allura Clarity 20 system. And as you can see, most of the adjustments we have to make during the intervention itself can be made tableside. Therefore, Mr. Chairman, as a conclusion, I think Vessel Navigator combines high-quality fusion techniques with a very intuitive and easy workflow. It enables us to reuse the preoperatively acquired CT images and therefore reduces the need for contrast and enhanced runs. Indeed, no new runs are neither necessary when the table or the C-arm position are changed with a classical roadmap system is necessary, of course. Adjustments can easily be made from the table side, and therefore radiation and contrast dose are lowered significantly, operative time shortener, certainly in more complex interventions. I thank you for your attention.
Well, thank you very much for this very clear and elegant presentation. The paper is open for discussion. Do we have any questions? Thilo Kölbel.
Thank you very much for a nice presentation. It looks very, very good. The one information I was missing is the learning curve to learn how to use that system and the time required for each individual patient to do calibration, marking of the ostia, etc. in minutes. How much is that?
Well, you know, I have been using fusion techniques already since a few years, and actually we stopped at a certain moment because it was too cumbersome. The big advantage of this software tool is really that it's so easy to use. And I have one of my assistants here. I will let her answer on how much time it takes to do this, because actually people in our department, they fight to be able to do the registration and planning phase. It only takes 5 minutes.
Okay.
Evelyn?
So 5 minutes.
Yeah.
Okay.
Really?
That's very good.
And it's it's very intuitive, so you learn it very, very rapidly. Yeah.
I don't see any more questions, so thank you very much once again. And now I would like to ask Dr. van Strijen to talk about dose management during complex endovascular interventions. Please, podium is yours.
Thank you, Mr. Chairman. What I would like to discuss with you is one of our biggest concerns in the entire setup. Whatever we do the entire day, radiation is always a big concern for us. What is important for us? Well, first of all, radiation is invisible. We all know. Therefore, if we do get complex situations, we tend to forget about the radiation. The radiation we keep using. It's noticeable to most operators. If we look at the scale of an individual patient, usually it's of little importance unless this patient must have repeat interventions. And finally, the use of radiation is quite often justified in the acute ill patient or in treating serious medical conditions. When we look at the X-ray dose, it's a growing concern. The number of X-ray exposures in the world is constantly increasing and has been since the 1980s. We see that the collective X-ray dose now has doubled. And we also see that the annual effective X-ray dose from medical procedures has increased 6 times since the 1980s. That probably also is reflected by the number of radiology exams per year globally, which is now something like 2.5 billion. A few words on X-ray dose. It's also dependent on the rapidly increasing procedural complexity. What we see in the previous speaker is that we now also use this technology in doing very complex procedures like Evar vertebroplasty. We have been using it for quite some time in uterine fibroid embolizations. Quite radiation consuming are biliary and upper urinary interventions, and also one of my personal favorites, needle guided ablations. We see that the increasing X-ray dose is a concern. If we look at this summary by Dr. Mettler et al. In radiology in 2008, we see that most of the procedures are well within acceptable ranges. But if you look at the lower half of the table, you see that especially abdominal angiography or orthography, something we do quite often, transjugular procedures and pelvic vein embolizations, they can add considerably to the patient's dose as well. A clinical example we probably all know from literature is this case of a radiation injury in a 60-year-old woman subsequent to a successful treatment of acute stroke. Since the results of the Mr. Clean trial, we do a lot of inter-arterial stroke treatments in these days. So this is quite a concern to us. The estimated fluoroscopy time in this particular patient was somewhat over 70 minutes with 43 imaging series, and this is the result for long term for this particular patient. Another example from the interventional cardiologist, we see this radiation injury in a 40-year-old man. At first, it's 6 to 8 weeks. There's a little bit noticeable. Most people think that it's actually resolved by the time you get to about 3 to 4 months. But if you go to the long-term period, you see that this patient needs a lot of plastic surgery and operative procedures to actually correct this skin defect. What about radiation in the cath lab? If we look at X-ray tube operation time and we compare it to the total radiation to staff and patients, we see that fluoroscopy, the actual catheter placement, takes up about 95% of our X-ray tube operation time. On the other hand, if we look at the total radiation to staff and patient, it's only less than half, about 40% of all the radiation actually is harmful for staff and patients. On the other hand, if we look at the acquisition of diagnostic images, although it only comprises about 5% of X-ray tube operation time, you see that's well over half of the total radiation to staff and patients. What can we do for potential dose reductions? I've put a lot of effort into developing virtual training facilities in being able to teach young doctors and fellow interventionalists in difficult and complex procedures. What else can we do? Well, most of us, we are pretty much familiar with potential dose reduction, like the dose awareness we have, the monitoring we do, and also taking some other tools that prevent us for getting too much radiation as an operator. The potential dose reduction was also, in a way, more feasible by using flat panel detector systems and chromium CT overlay guidance, a technique we saw in the previous speaker as well. And by using this information, we now have fusion imaging available as well to guide our procedures. Finally, I won't go into detail because the previous speaker has excellently showed the value of potential 3D road mapping in catheter guidance and optimal angles in Evar procedures as well. What I would like to discuss with you is actually the essential part of my talk is what can Philips Clarity IQ technology mean for us. This is a very complex DM with a lot of information, a very complex slide with a lot of information. What you see is now that it's feasible to fine-tune live over 500 different parameters of the Philips system live while we are acquiring the images. And how does it work? Actually, the technique that's being incorporated is a flexible digital imaging pipeline where we can use pixel shifting, automated image enhancement, where we can use motion compensation and noise reduction to actually make our images better when we use less radiation dose. And we all know that this is actually, this needs to be flexible as we have different interventions, different indications where we work on, be it in neuro interventions, be it in cardiologic interventions, or be it in peripheral interventional procedures. One of the techniques I would like to show to you is the reduced motion artifacts, where we do a DSA acquisition without automatic motion control. And once we incorporated the automatic motion control, you see that the images actually increase quite a bit in fineness, in contrast richness, and actually this is all done automatically by reducing the patient motion. Another technique that's being used is spatial noise reduction, and spatial noise reduction in this case is shown in a coronary intervention. The technique is now capable of identifying the true object, preserve the true object, and average out the noise around the object, where we can have this very nice results in high power magnification. One of the first studies performed to show the benefits of dose reduction in interventional neuroradiology came from the Söderman group, and actually he was able to demonstrate that they were able to perform the same interventions with 75% dose reduction without a single loss of image quality. And here are some examples from this study. On the left you see the current system, and on the right you see the 75% dose reduction. In my hospital, we actually performed a study on the effect of Clarity IQ in pelvic and peripheral digital subtraction angiography. We performed 2 series, 100% and a 60% series in random order in 50 adult patients, and we then performed a blinded image quality comparison with experienced interventional radiologists that were not Philips affiliated. Here are some slides showing you the results. On the left again you see the standard image quality, on the right you see the Clarity IQ image quality, where we were able to perform a significant dose reduction, and you can also see that the image quality is preserved. Another example, actually focusing on the infrapopliteal arteries. What you see here is that the fine detail in this small AVM is actually better visible on the Clarity IQ images as well. The study we performed in iliac imaging, here you see the results of one of the patients with a bilateral iliac stenosis. On the left again you see the dose values, dose area product values and air karma values compared to the Clarity IQ. And in this particular patient you see that we are able to do an 86% dose reduction without loss of image quality. What are the results? We compared total and per frame air karma and dose area product values, and we were able to show that the reduction in radiation dose was well over 80% with this low dose imaging, and these are currently in press. These are the results from the blinded reviewer comparison, where we see that 14 of these paired images, the image quality was considered better in the image in the Clarity IQ patient group. They were similar in 32 patients, and we had 2 patients where the blinded reviewers judged that the image quality was actually worse. I took these 2 data sets to show you what the differences are between the 2, and you can see that there is a slight difference, but the difference is not such that the image quality is not good enough to perform a procedure. We also did scatter dose measurements as a prospective comparative study to see what the radiation dose would be for the operator, and we saw that the staff dose present in the room during these particular type of procedures actually were subject to a dose reduction of 70%. Well, you can imagine that the first clinical feedback is without exception very positive. All the participating interventionists were really excited to see that we are now capable of performing these procedures with such a huge amount of dose reduction. And I think this actually is one of the leading standards for the next few years. A clinical example, if you look at this image, and I first didn't notice, but this is a patient that was in shock, that was actually treated for gastrointestinal bleed. And as you can see, the patient is moving constantly. The patient is breathing heavily, and still we are able to see all the very fine, detailed vascular structures in this particular set. And these images are very, very challenging. I will replay the same movie again, and you see the moment the patient starts to move, still you can see the very fine arterial structures are well defined. Okay, coming to the discussion. What is this technology important for? Well, we find it especially important in young patient groups, patients that are treated for oncology, patients with congenital or acquired diseases, patients that need repeat procedures. We see the challenge of more obese patients every single day. We see more complex procedures that definitely require us to be cautious with too much radiation. And also we see that we do quite a lot of interventions at close range. In fever procedures particularly, but also in non-vascular interventions, we see that we stand quite at close range while working. I therefore would like to conclude that lower extremity digital subtraction angiography is now feasible with over 80% mean dose reduction without a compromise to image quality using this new image processing technology. And all the images are rated as equal to or better than those obtained with standard imaging for 96% of comparisons, with a good agreement among reviewers. I thank you for your attention.
Well, thank you very much for this very clear, pro-clarity talk. Are there any questions? Maybe I will ask the same question that I asked a year ago, and that is it possible to update your current Philips system with the clarity, or any Philips, or do you need a special version?
Any recent acquired system, any system that is currently available out there is capable of being upgraded with this technology. It does not take a big change of the actual C-arm system itself. The majority, the big change that is in the system is actually a software change. What you see now, the images I showed you, are actually the result of extensive calculations, real-time calculations, to be able to provide this image quality. So there's a small change necessary on the system, but the biggest change is software, which is actually very well fitted in retrospect.
Yeah, okay. Any other questions? No, it was quite clear. Thank you very much. And now I will call the final speaker, who is well known to all of you, Professor Jim Reekers from Amsterdam, who will talk about something that interests not only radiologists but vascular surgeons, and that is, what are we really doing with our revascularization? Do we get any better perfusion? Please let us know.
Thank you very much, Mr. Chairman. Ladies and gentlemen, what I'm going to talk about is a little bit more also work in progress. We're almost there, and we do have Philips does have a product out, but there's still a lot of things we have to sort out. But I just want to give you a sort of a first impression where this all will lead and why we are doing this. This talk will cause also a little bit of basic information, but just some things you learned at medical school. But nevertheless, some refreshments is never a problem, I hope. I have nothing to declare. I also have no financial relation to Philips, maybe, to tell you this. This is the research group. We're working in our hospital with several departments on this new technology. I give you a case, and the case is very important because this is actually one of the reasons why we started off with this project. 72-year-old female, diabetes type 2, non-healing ulcer at the foot, typical sort of patient we tend to see. You look at the angio, you see there is a very diseased below the knee area. The popliteal artery is already diseased, and there's only a peroneal artery. And if we go a little bit more down, you see the peroneal artery just gives a collateral to the posterior and to the plantar arch. This is a sort of a patient we see, and we then have to have a discussion. What are the treatment options? Well, none to advise direct amputation, PTA of the SFA and popliteal and to see what's going to happen, recanalize the peroneal artery, or recanalize as much arteries as possible. So we started off doing this patient, and we were very, very lucky to get away. We were able to reopen both the peroneal and the posterior tibial artery in a subintimal way. As you can see, very good result. You see it's coming down, the blood is very good angiographical result. We were all very pleased with the result. You see the good filling of the vessels now into the foot. And we did some follow-up. And in follow-up, there was no wound healing infection, and 6 weeks later, everything was amputated. There was no occlusion of the vessels. We have revascularized, and still we have, at 6 weeks' time, despite the good result, there was an amputation. And the question is, why did the wound not heal? Well, did we not bring enough blood to the foot? Probably we brought as much blood to the foot as possible. So there must be another reason. Maybe there is something in the foot which is just not capable of handling all this blood. Maybe there's a very poor microcirculation which will not cope with all the blood we're bringing down there. Or maybe it's a combination of both. So the critical issue we have is, and we have this every day, how can we predict the result of our revascularization? We do a procedure, we're very happy, but we do have to keep our fingers crossed and see what's going to happen. And even if the ABI goes up or the toe pressure goes up, you still see sometimes that it doesn't go well. So we have to have something to look at both during a procedure. We now look at the angiographical success, and I just showed you that's not always a good indication what's going to happen. And we can look also after the procedure to toe pressure and other things. And again, this is probably not what we should do. What this meeting is all about is about this. It's about pipes, about making new pipes, making beautiful pipes, and this is with stenting and all sort of other technologies. This is what we are currently focused on. And this is actually 95% of this whole meeting. However, what we do measure is also the result of what we do with our new pipes. We look at ABI, toe pressure, ankle pressure, and next to that is all measuring how good are the pipes. And we should be looking at other things, and because we are concerned about ulcer healing and prevention of amputation. And this is actually this is a paradigm shift, and this is something I want to bring over to you. We should look beyond what we're doing in these new pipes. We should also look where is the blood going to. Because if you bring blood to an area which is completely unsuited to do anything, if you bring some water to this sort of ground, nothing will grow there. So the whole idea is we also have to look beyond the pipes we are just making so beautiful. And this is the end organ for critical limb ischemia. It's the foot, because in the foot all the things happen. In the foot you have the ulceration, in the foot you have the ischemia. The foot is the very important end organ for CLI. And if you look at a picture like this, we're all focused and trained to think about that the ulcus is the problem. The ulcer is not the problem. The ulcer is just an expression of that there is a local problem because there is a wound which is caused sometimes by a little trauma. But actually, this is a sign that the whole foot is diseased. So it's not a single area which is diseased. The whole foot is diseased. And this is just an expression of this disease. And we hear a lot about the angiosome theory. And, well, if you have an ulcer, it's not true that only the vessels to the angiosome are diseased. Again, all the vessels are diseased, but only the area of the angiosome, the area of the ulcer is just the site where you need some extra blood to solve the problem. So we go beyond the local ulcer, we go beyond that sort of thing, and we try to see CLI as a disease of the foot, much more than a disease like an ulcer or so on. So this is something which, I mean, I talk about this quite often, and I always find it difficult that people have to make this step to say, to look at, not at the new pipes you're laying, not at the ulcer, but to think in a much broader way about a disease which is really universal throughout the foot. So, and we know, of course, that, and there's a lot of publication on this, that in patients with CLI and non-healing wounds, an estimate of 10 to 20% of wounds will not heal and will finally result in amputation, despite optimal revascularization and enriched wound care. And it's known that there are also amputations with open bypasses. So there is more than only bringing blood to the foot. And in clinical reality, we also know, there are papers, and there are much more papers on this, that about half of the patients with CLI and which have something which is really, according to the consensus document, still will heal without any revascularization. And the other clinical reality is that the outcome of wounds healing is only 50% dependent on successful revascularization and wound care. So, if we look at the whole spectrum, you see that about 50% have severe ischemia, but maybe don't need direct revascularization. About 35, if you don't do anything, they will amputate. And there are about 10 to 50%, whatever you're going to do, they're going to be amputated. And if you now take the blue and the red bar together, that's 85%. And that's exactly the figure you hear all the time. If we do a patient with critical limb ischemia, we revascularize, you see that it's 85% limb salvage. That's true, but probably 50% of that was just, you get it for free because those patients would never have been amputated. Anyhow, so what we do now with perfusion angio, it's an extension of the angiography, and it's a post-processing tool. It's something you do after you made the angio. It looks at the quality of the microcirculation of the whole foot. It's actually a parameter for peripheral vascular disease, but it does not look at focal disease, not at the angiosome. It's a 2D technique. That's not a 3D technique. It doesn't focus on a specific place. It's a 2D technique. It's a summation of the disease in the whole foot. And what we do, and I'm a radiologist, and we are used to doing things we call functional imaging. We do it in the brain, and we do it in other areas. And this is actually what we're doing is also functional imaging, to look at the quality, to quantify the result of our intervention by the change in perfusion. And that is functional imaging. And we do that on the angio table to answer the question, how much perfusion is needed to obtain a good clinical outcome? So do we need to reopen another vessel or not? And we do it instantly. You get the information back from the software within a couple of minutes. So that's one thing. And the other thing we do is also, and I show you an example of this, to measure the change in perfusion after pharmacostimulation. And we do that to answer the question, is the microcirculation of the foot capable to use an increased flow after revascularization for better tissue perfusion? In other words, if we bring more blood down there, is this going to help to heal the ulcer? Or is it not possible anymore? And is the foot beyond any form of repair? So just give you some basic principles. Everybody knows about this. We have a microvascularization, we have the microcirculation, and we have the venous return. This is quite all the picture you can find in a lot of books. I just go over it very quickly. And what we see here is sort of a very basic thing. But what is happening in the foot is you bring the blood inside. If we're in a healthy situation, the vast majority of the blood is going to be shunted away. So none of the blood is going to be used for tissue perfusion because we don't need it. The moment you start running, everything's changed. But if you have ischemia, you need much more blood going to the tissue, and so then things change. So the AV fistula will go down, and more blood will go to the tissue. That's an automatic regulation system which has been known for more than 50 years now. And if you then bring your blood to the capillaries, how does it get to the tissue? Well, it gets to the oxygen just diffuses. Nutrients just have to have some little arterial pressure. But what is very interesting, and that comes from CT perfusion, what's done in the cardiology world, it's now abandoned, but they did it for about 10 years ago. You see that 30 to 40% of the contrast also goes into the interstitium. So you can actually image the contrast which is in the interstitium. So what we do is quite simple. We give contrast, and we measure the density over time. So we make a time density curve, and that gives us a lot of information because it shows us the relation between the flow in the capillaries, the diffusion of the contrast to the interstitium, and the AV shunting. So what's happening in the foot is all seen in this curve. AV shunting is on the left, going in and out, and capillary filling is with a plateau where it stays in the interstitium for some time. So perfusion angiography is nothing more and nothing less than time density curves in a 2D summation, and you use the original angiographical data for that. You don't have to give any extra contrast, any extra radiation. It's just already the information you have there. So what is now the most difficult paradigm shift? And the thing is, and I can't repeat it enough, it's not the macrocirculation will determine the final outcome, but it's also the microcirculation and looking at the whole foot. The whole foot is diseased. It's not only the angiosome which is diseased. The ulcer is not the area of the most disease, it's only the area in need of the most blood supply. And if you do a perfusion angio, you have a couple of parameters. Your contrast volume, your density, your inflow, your outflow, your microcirculation with capillary flow and AV shunting. And let's forget a little bit about the collateral situation because that's another thing we have been looking into, but it makes it a little bit too complicated. But Contrast volume is controlled. Contrast density is controlled, inflow is controlled. So the only thing which keeps left in the equation is microcirculation. And of course, you have to do it in a special situation. If the foot is moved a little bit, then the picture is gone. So we have made a dedicated footrest, and it turns out that patients really like this footrest. Even if they have severe ischemia, they're really able to hold their foot very still. And you get this sort of pictures then. What we do, we take a large region of interest, and we try to get a picture. But a minimal basic signal is needed. If you have a patient where everything is occluded because there's peripheral trash, there's no blood coming in the foot, you don't get a good signal. It's important. The other thing is you have to have high contrast, high density contrast. So if you dilute your contrast, you get a very disturbed signal. You get a signal, but very disturbed. So the parameters have to be very fixed, otherwise you don't get a good signal. So the inflow, the density of the contrast, everything has to be very, very fixed to do this. And then you look at this, you see the region of interest. If you look at the picture with the arrow, you see that we have revascularized the anterior tibial artery. And if you now look at the curves, you see there's a huge increase in perfusion after you've done that. You see the blood's coming in much earlier, but you can also look at the area under the curve, which gives you an impression how much more perfusion there is. You can also look at the shape of the curves. We have seen that diabetic patients and non-diabetic patients have different curves. We have not figured it out what the real difference is, but we're going to work into that. But we do see differences in that sort of patients, which is important information. And the pharmacostimulation, that's what we do is with tolazoline. Tolazoline is a medication which is in Holland registered for pulmonary hypertension in very small kids. And what we do, we actually block the catecholamines, and then by doing that, you get a vasodilation of the capillaries, and they will increase your AV shunting. And I give you an example: female diabetic type 2. Let's go over it. If you look here, this is a huge calcified vessels. You see this, but it looks pretty well. The blood is coming to the foot. We looked at this patient. We could not figure out what to revascularize. I mean, there is one vessel open, but there is no real thing I think we could do in this patient. So we only did a pharmacostimulation, and we see pre and post. There is absolutely no difference. So this means the vessels are not capable of reacting to any stimulus, and blood flowing inside is also a stimulus. And we said this patient has no options anymore. And a follow-up of 4 weeks showed there was an amputation. On the other hand, we have a patient with a very low toe pressure, and again, you see a very, very severe peripheral disease, and then the red bar is after tolazoline. You see a 25% drop, and that's what you want to see because there's a faster flow, which means a drop in the curve, and this patient did very well afterwards. So again, we can before already measure what our intervention will do. What we call this the fractional reserve capacity of the foot, and it can be speculated. We have to do really more research to go into this and to do more trials, but it can be speculated that it could be a very crucial parameter for outcome. And when there is no or minimal fractional reserve, probably the outcome, whatever we're going to do, bypass or endovascular, is going to be bad. We have to, of course, do this in a prospective trial. We're looking into this now, but it's a very new way of thinking about CLI. So ulcer healing is blood inflow. It's the ischemic state, but especially also the quality of the microcirculation. And to summarize, perfusion angio has the potential to measure the perfusion changes after revascularization. We do this on the table, so to determine an endpoint for revascularization or to predict outcome. It can also determine the quality of the microcirculation. And of course, it can do a lot of other things when we're thinking about what can we do, looking at with stem cells and so on. But nevertheless, this has a really big potential to be a very important parameter, much more important than all the other old parameters like toe pressures and so on, which really didn't help us very much to predict outcome. So we're starting a trial in 2015. We're going to do actually 2 trials to look in all these things, how it really work out in clinical practice. But I think it was a great opportunity to give you sort of an insight where we're working on and how we try to improve and really to revive angiography for the next generation. Thank you very much.
Well, thank you very much, Jim, for this very thorough talk. Do we have any questions? There's one there.
I really admire the work. I mean, is the software needed in the Angie suite? First, is it too expensive? Second is this perfusion angiogram. Can we do it just before our intervention? I mean, this pharmacological challenge perfusion angiogram, the one that you give terazoline and so as an adrenergic blocker, and then you have your angio to see whether there's a change or not. Well, if that could be a prospective, this patient will value or get a value of, especially if the inflammatory the diffuse disease, going to value of this or not.
There are a couple of things here. First of all, if you give this tolazoline, it will work about for 2 hours. So that will give you a little bit of a problem here. But you can use it afterwards. So that's not a problem. The way to look at it on the table is very easy. The software, by the way, is available from Philips. I have no idea what it costs. You have to talk to Philips about it. Okay. But it's available and it can be used. But what I want to stress, if you want to use it, it's very important to really keep very strict to the parameters. Because if you do a hand injection, or you do, or the foot is moved, or you use low density contrast, your signal will not. So it's very, very meticulous how you do it. But if you do it in a meticulous way, we've done more than 150 patients now, and you will really see that it's really stable way to do this. But it's just another way of thinking about CLI. It's more dynamic. It's functional imaging.
Thank you very much.
Cliff Sherman.
Thank you.
Cliff.
That was a really fantastic talk and really exciting concept. But my understanding of microcirculation is a lot of factors will determine vascular permeability. Some of those are local, like untreated infection. Some systemic, like right heart failure, low albumin. I couldn't quite understand how much of your technique would actually bear to distinguish those factors, which are potentially correctable, as opposed to those which you kind of implied were just due to basic unrevascularizable tissue. Is it possible to distinguish that?
Cliff, I have absolutely no idea, to be honest. And that's why we're going to do this trial. I think we've seen that there is a difference between diabetic and non-diabetic. But we all know that, for instance, in diabetic, there is a thickening of the basal membrane with leakage of blood into the interstitium. So there are other mechanisms there. I have no idea. That's why we're going to do this prospective trial, to look at the perfusion data and to correlate them with this specific disease before we can really come out and say this and this is good. So I have a pretty good idea that this will help us to determine the patients which will respond and not respond, and those will have really CLI and will have only severe ischemia. But I'm not that far that I can really already tell you that all the other factors which really play a role in diabetic foot disease, how they will play a role in this, just don't know. We have to go on and investigate this pathway.
I have a short question and a short answer. You give me a short answer. The question is, can you do this on site or do you need post-processing? Because then if you could do it on site, you could pick out those patients where maybe a revascularization is not of any value, or you can say, well, we have done something now, and now this ulcer will heal.
It's no problem when you do it on site. You get the software. It's available, and you have the pictures on the screen in 2 minutes. Okay. It's really on site. It's very, very fast.
Okay. Well, then, thank you very much. And by that, I would close the session.